Today we'll talk about hyponatremia. Hyponatremia is a really common electrolyte disorder, and it unfortunately is a real significant cause of mortality and morbidity, particularly in older adults. Look at the cost associated, 3.6 million, and that's related mainly to hospitalization, but it's a significant financial drain on our healthcare system also. There's many potential causes of hyponatremia. So again, just a tremendous amount of things that can cause hyponatremia, from infection, traumatic brain injury, malignancy. I would like to pull out a couple. Endurance exercise, all through your chapter. There is so much information about that. And I want you to pay attention to that, particularly, and med side effects, endocrine disorders, and that psychogenic polydipsia. So a psychological disorder that makes people drink and drink. So it can also be related to ADH, hyperglycemia, hypokalemia, adrenal insufficiency, pregnancy. So there's even more, and you can take time to review, but extract out of that what we would see in primary care, okay, just over and over. The definition of it is serum sodium less than 135 milliequivalents liter. So we also see hyponatremia after surgery from fluid overload, from just giving too much fluids. Initiating thiazide and other meds like Tegretol, some anti-seizure meds. Chronically, usually those are outpatient, they're more subtle, but if those patients come in and they have falling and gait issues, cognitive changes, and osteoporosis, you have to put that in your differential. Look at that, 10% outpatient population. So this is common, and you should be able to pick this up, and should pick it up. More common electrolyte disorder, but it's especially in older adults and children. And again, I'm going to direct your attention to that exercise-associated hyponatremia. Look at that in detail on 1114. Treatment is always a challenge, according to Butera, and I think that's true because different treatment modalities for different situations, and even guidelines have been created, and I posted one in your module. There's several. For that exercise-associated hyponatremia, the Wilderness Medical Society, I actually found a compilation of several guidelines. I just want you to review it so you know the complexity of this and that you have some tools. Patho-wise, just remember, if sodium falls below normal, serum osmolality is decreased and extracellular water is allowed into the cells. That's considered hypotonic hyponatremia. And so people experience cerebral brain swelling, and that is what causes those neuro features of hyponatremia. I want you to review the pathophysiology or the pathogenesis of exercise-associated hyponatremia, the psychogenic polydipsia, and the beer podomania and hyperglycemia. I must admit, I had never heard of beer podomania, and that is where a person consumes so much beer that they put themselves in major risk, besides all the other obvious reasons, that it lowers their sodium. And you can understand that'd be very significant for me. I am working in a clinic on a college campus, but it'd be significant anywhere. Clinical presentation, often subtle, okay? And it's interesting, Butera tells us, okay, so if the patient comes in with all those complaints, you need to think about what their sodium level is. So I think that's pretty telling. Look at those complaints: headache, blurred vision, dizziness, lethargy, weakness, irritability, restlessness, impaired central nervous system, falls, GI complaints, influenza-like complaints, cardiac respiratory distress, dyschezia, unusual water drinking behavior, and weight changes. Well, that's going to be in a lot of our population, but this is exactly why you have got to take a thorough history and present and past look and drill down medications, alcohol, allergy, recent illness, psychiatric history, exercise history, and pregnancy. It's just vital because that list is so long. You're keeping hyponatremia in your differential. Physical exam has to be comprehensive, and particular emphasis on vital signs and that comprehensive exam and orthostatic blood pressure measurements. And then I want you to review the diagnostics on page 1116. There's several tests that are appropriate when you're trying to differentiate and diagnose hyponatremia. Differential diagnosis, again, I want you to review. I just want you to know the main ones. So we talked a few minutes ago about medication. Was it initiated? Are they endurance athletes? I thought it was interesting that our author said you've got to differentiate between endurance exercise versus an acute altitude illness, and then dehydration. Don't miss the obvious, in other words. So take your time to look at that. Now, management in primary care is often it's directed at what the cause is, of course, but it's almost always medication related from those patients coming in primary care. So that's where I'd really focus on building my toolkit as a primary care provider. You want to obtain a serum sodium prior to starting a medicine that you know could affect sodium, lower it, but within 5 days of starting that med is considered to be appropriate. Even if you see a slightly lower than normal from that initiation, that should be concerning and probably prompt, unless it's benefit versus risk, stopping that med. And then there's some also, if it's exercise induced, a lot of times we'll have those patients add salty foods. Complications, very serious. Brain damage or death from encephalopathy is the most serious. But you understand the risk of falls and central nervous system changes and alterations. So we're always going to refer for an acute hyponatremia, acute on chronic hyponatremia, moderate to profound symptomatic hyponatremia, and then chronic patients that are really recalcitrant to any therapy, so they're just not responding. I don't know that I think I was taught to take this as serious as it is. Matter of fact, I know I wasn't. And the more I work and gain knowledge and experience, the more I recognize that this electrolyte disorder shouldn't be missed. Patient family education, how do you prevent exercise associated hyponatremia? And there's some good suggestions about it, about not overhydrating, replacing sodium. And a big one for anyone is to recognize the signs of the disorder. Thank you.